In the first presentation about the NfL, we had data from two large, deeply phenotyped cohorts from the US and Europe. We have data from the EPIC cohort at San Francisco, where I work, and we have data from the amazing Swiss multiple sclerosis cohort, which is a collaborative effort of around 8 centers in Switzerland. Those cohorts have together more than 13,000 visits where we have NfL values. We use those NfL values to try to find if there is a temporal association, if there is an association between the time of NfL elevation and the occurrence of disease progression. So we classified the patient the way we see them clinically. When I see a patient and I find their EDSS score that worsened, we looked backward and see, okay, what happened one visit before, what happened 2 visits before? And we had very interesting findings in that we found the NfL elevation to occur before we diagnose the progression based on our EDSS score, not actually when we see the patients. So if you see those subjects or those participants who had disease progression associated with a relapse, this NfL elevation was around 1 year before that. And if you look at the subjects who have NfL elevation and who have disease progression without a clinical relapse, the elevation was even more delayed, was between 1 to 2 years before. And if you try to then use this NfL elevation to predict the disease progression, we have a very clear finding that high NfL values were associated with a disease progression event associated with a relapse within a year or independent of clinical relapse within 1 to 2 years. So the findings from these cohorts are very relevant for both the application of NfL to measure progression and also for our understanding of progression itself. So if you want to utilize NfL to understand disease, to predict the disease progression, you have to be very careful about when you are measuring NfL and at which time point you are trying to predict the progression. And on the other hand, it tells us when we see a patient and we diagnose progression, that pathology inside the brain that is associated with this progression happened around 1 to 2 years before. When we see the patient, there's almost nothing more we can do, but we should really, in all our clinical trials, aim to prevent the occurrence of this progression over this prolonged period of time. I think the fact that realizing when we see the patient having progression, the damage in the brain happened before that, is critical insight for clinical studies. So if I want to design a clinical study and I want to use that to prevent progression, or you want to use my intervention to prevent progression, if an event would happen in the first 6 months, there is no way my medication could impact this event because the CNS damage happened 1 to 2 years before. So we really need to be sure that our studies are designed to cover at least 2 years of time period to be sure we impact this window where the damage is happening. And the same in clinical care, if we are using one of our medications with the particular aim that we want to prevent an ongoing progression in our patient, we can't evaluate if this medication worked or no within the first year. Probably we need to wait longer before we decide. That might be challenging and it might create other challenges in the clinical setting and clinical trial, but we definitely don't want to miss this time window where the active damage in the brain is happening.